Good afternoon, everybody. At the outset, I would like to thank Dr. Reema for giving me a chance here. And my job has been made a little easy by Sir's talk, Professor Gupta's talk, and Dr. Vishali's talk, because they have elaborated that what we are not going to miss while we are treating these patients and non-infectious uveitis. As we already know, that with the better understanding of uveitis and the ocular investigations in the labs, the skew is towards making all these non-infectious uveitis, which we were treating with steroids, towards now we are blaming it on some infection there. And this is good, because rather than treating with systemic steroids, targeting on a target there, the infection there, it's a better approach. Rather, we were blaming the God's hand, environmental, genetics and everything. So it's better to rule out the infection. Working up a uveitis patient reminds you of your final prof actually of medicine, and you are in the medicine ward and taking the history for 1 or 2 hours before your professor's round, and you should give it that kind of a time to the uveitis patient after you have seen the eye and made differential. Then go retrospective and ask everything from demographics to the places he visits or his hobbies, his pets, everything. So with that, the classic teaching is you can reach up to 70% of the diagnosis. So as I've already said, after the history taking the systems, you have to look at the system as a whole. You may be sitting in a very busy clinic, but you have to have this kind of a workup in order to place the diagnosis in these patients. So it is very important to have a systemic history, ocular history, and systemic examination if you are suspecting these disorders. So as Sir has already said, that this used to be, this is rather, the anterior uveitis, mainly it's non-infectious and non-granulomatous. The only variety he has shown you is the viral, where you don't miss those high pressure, where don't you miss those iris atrophy patches. Then these are non-infectious variety anterior uveitis. And you know that the classic triad of pain, redness and photophobia the patient comes with. And you have to look for these seronegative spondyloarthropathies, and you think of these ankylosing spondylitis, the reactive arthritis syndromes, the bowel disease. This is where the patient, you have to ask the patient the history of any rash in the body, anything wrong with your bowels, anything which is he is not telling you any rash anywhere in the foot. So this is where we'll place the diagnosis, and the history will tell you that whether the patient has been operated or has any drugs been taken. So you can rule out those kind of diseases there. But in case that there are signs that this is going on for years altogether, then the entities like JI and Fuchs has to rule out. If you talk about the granulomatous kind, of course, you can see sometimes granulomatous in the late stages of these cases also, but the granulomatous is mostly sarcoidosis there. So these are the signs which we see in these patients. These patients shows these kind of a synechiae. They are not broad-based; they are filiform kind of a synechiae there. They can have cells, coagulus, massive fibrin, and these kind of findings of a sacro-like joint, this kind of a posture there. Again, there are many cutaneous signs which you have to look for. Tells you that it is a case of an anterior uveitis, which is of non-infectious variety, where you really need a treatment which is local as well as systemic if a patient is suffering from any associated this IBDs or reactive arthritis or the psoriasis there. Like next is JIA. In a child who is in a female rather, okay, these are very common actually. This is one of the commonest systemic disorder associated with anterior uveitis, and pediatric evaluation and ANA testing is very important. This is an asymptomatic kind of a uveitis. The patient may come to you with a bound down pupil with a BSK there, and of course these are the complications which rather bring these patients to you, the cataract there, or the patients don't come in the acute stage in these patients. And this kind of pictures when you see in these eyes, they can vary from they can present early or as a late with BSKs. They can present as late as a hypotony there or cyclitic membranes there. So they can come very late. These are the patients which require a pediatric evaluation is must, because these diseases, the ocular signs can be present in an active patient of JIA, or they can present early to you also, but later on they develop these symptoms. So they need to be treated with the
association with the pediatrician there, and they need these systemic therapy apart from the local therapy you are going to give to these patients. Of course, the Fuchs, the heterochromic uveitis, the frequently overlooked disorder, but it comes with a blurring of vision there, and practically no therapy is there. There's advancement here. The people are trying to put this kind of pathology to rubella or CMV also there. The classic signs which you see, the KPs not following the arc triangle rule, or you have a cataract there. So the clue here is patient doesn't have a synecdoche here. No synecdoche, unilateral, non-inflamed kind of an eye with stellate KP clinch your diagnosis. They may present with a lot of vitritis, so vitritis can be there in these patients, but there will be no CME. So these are the clues which you follow, and this is a very most overlooked kind of a uveitis, and need not any treatment unless until they develop a cataract that they will need surgery later. So next comes the intermediate uveitis. So this was one of the commonest cause of non-infectious. We used to call it a variety called pars planitis. That 80 to 85% cases are non-infectious there. But nowadays we are associating with these. Some cases are of syphilis or sarcoidosis in our population. Tuberculosis is there. It can be causing these intermediate uveitis. The diagnosis, again, I said clinical there. If you have the findings, more of a vitritis there. If you find these snowballs, you have these snow banking in the inferior area, and you have the CME, and there is a less of an anterior segment reaction. The synecdoches are common but rare. But if you see synecdoche, then think of infectious variety. And if you have synecdoche, sometimes you need these kind of ultrasound biomicroscopy to rule out these the snow banking in the inferior pars plana. Of course, the treatment is, as Dr. Vishali has already said, this is the one case. If in case it's unilateral, they can respond very well to the local intravitreal steroids in these patients. And of course, if not treated, they are associated with cataract, glaucoma, and others. Of course, now is the variety called posterior uveitis, and it basically involves the retina, choroid, and vasculitis. As I see it, the retinitis, if you see, I mean, like sir has already shown you lots of examples of retinitis. Retinitis is mostly infective, be it just leave behind Behçet's and sarcoidosis there. So if you see a retinitis patch, you don't think on the lines of steroids. Keep your antennas up, think of infections there. And if you have solitary focal chororetinal lesions, again, think of your toxos, think of your TBs, rather than thinking of the non-infective variety, which can be just sarcoidosis. And so there are certain clues there. If you see retinitis or the focal chororetinitis patches, think of infectious variety. And the multifocal is there, and these what we call as white dot syndromes. And these are the syndromes which nowadays we are in our population, we are investigating them for syphilis and TB. And until we exclude them, only then we are treating them with the steroids or the other immunomodulatory drug. But we have to rule out the causes of TB and syphilis in these patients. As you have seen, lots of our serpiginous choroiditis patients can present like TB, like serpiginous choroiditis, and multifocal choroiditis can be due to tuberculosis there. And other is the stromal inflammation in case of birdshot and VKH there. So, as far as the vasculitis is concerned, the clue here is the infectious and non-infectious. What I think is the presence of these cotton wool spots, with or without hemorrhages. If you see these cotton wool spots, you don't see cotton wool spots in sarcoidosis, you don't see them in tuberculosis. If you see these cotton wool spots, the obliterative variety of vasculitis comes to your mind. You think of the systemic diseases like Behçet's, PAN. So cotton wool spots are the clue here. So with the cotton wool spot, you will see the BRVO kind of a picture. You can see a arterial occlusion kind of a picture. So rule out this non-infectious to infectious is, I think, the cotton wool spots are the real clue in these patients. Of course, once you know that you are suspecting that, then you ask the systemic history. You rule out your SLEs by Mallar rash, photosensitivity, cartilage signs, and all those. Again, I told you the history is very important in these patients to close the diagnosis, whether it's infectious or non-infectious. Now comes the pan-uveitis variety. it's as you know that all the systems are involved here, right from the anterior segment to the posterior segment. So it's generally bilateral. So there are 4 diseases which comes to our mind when it's non-infectious variety: sarcoidosis, then VKH-SO, and then the Behçet's disease. Sarcoidosis, as already said, it's included in the most of our differential diagnosis of primary uveitis, and HRCT is a very sensitive imaging tool to see the signs of sarcoidosis in the lung. And of course, this is, as I already said, you will see the granulomatous uveitis, you will see this, the Basaka nodules there, you will see, and you will see the classic optic disc signs, you will see lots of this vasculitis there, you will see the signs of the candle wax drippings. Everything is seen in these patients. They can mimic the tuberculosis, but the tuberculin test and the HRCT will give the clues that whether you're dealing with TB or whether you're dealing with sarcoidosis there. Again, the hilar prominence, the potato lymph nodes and the interstitial signs. Of course, you take biopsy from these lymph nodes and you can prove a granuloma they are sitting in these patients actually. In the VKH, it's a classic, again, a granulomatous panuveitis with the classical features which cannot be confused with any infectious variety of uveitis. And you can see these skin signs or the meningeal signs or the auditory signs along with, or later on they develop in the course of the disease. And there are set criteria there. And the presence of these granulomatous uveitis, presence of these bound down pupil, and behind that you see disc edema with serous detachment in these eyes, which can be sometimes seen as exudative audio also. And there are classical signs which seen on FFA and ICG, and these diagnoses cannot be missed in these patients. And of course, you look for the systemic signs, the alopecia there, the oleasis and the vitiligo patches, and of course the retinochoroidal thickening or thickening on EDI-OCT will give you the clues. In the late stages, by looking at the scars in these patients, you can place the diagnosis of VKH. The classically sunset glow at the nummular scars you see in the periphery in these patients, they'll give you the diagnosis that this patient had a VKH, and this recurrence we are seeing is of VKH only. Sympathetic ophthalmia behaves a similar way. Only the history of trauma or surgery is little different from VKH. So we see all the ocular signs in sympathetic ophthalmia also. Behçet's disease, I've already said, it's a chronic relapsing occlusive vasculitis. As Dr. Vaishali has already shown you, this disease is very chronic, rarely seen in children, but needs a very long treatment and known for the recurrence, and seen in the young second or third decade. And there is a international study group classification also given that when to suspect and what all is there to prove that you are seeing a Behçet's. Once you see ocular inflammation, you look for the other signs to diagnose Behçet's disease. And the signs, again, are already hypopyon uveitis. Once you see hypopyon uveitis, the differential of HLA-B associated disease comes to your mind. When you look back, you see the retinitis patches, you can see frosted branch angioitis, you will see obliterative vasculitis, and you don't miss these oral ulcers. The patient shows you these are very classic oral ulcers in these patients, the palate, on the lip. And of course, when they present late, it's a very obliterative vasculitis. It will be a burnt out totally disease with the optic disc pallor. Again, as Dr. Vaishali has already said, the therapeutics involved a prolonged course to prevent these ocular complications. You have to be very aggressive so that ocular complications don't develop in these patients. And if you don't treat them now, probably you will never get a chance to treat them. So the corticosteroids are the first line of drugs, and then the immunomodulatory. We can go to biologicals in these patients. They have to be treated with your physician friend in hand actually. To conclude here is uveitis is nothing but you have to read and read and read and see those things, because I believe that eyes don't see what mind doesn't know. And the one thing you have to remember, the diseases don't follow the books, because the rare scenarios can always be there, So the appropriate test and ruling out etiology is the key to success, so that you don't land up in these kind of mishaps like Dr. Reem has shown you. Thank you very much for your patient hearing.